Okay, thank you very much. So my task is to talk about the management and outcomes in acute coronary syndromes with atrial fibrillation and where can we improve. These are my disclosures. So perhaps underestimated is the event rate that occurs despite the current standard of care in patients after an index MI. We all think the acute phase is the dangerous phase, but 1 in 5 patients who survive the acute phase suffer MI, stroke, or death in the first year. And these are contemporary, nearly contemporary Swedish data. We previously demonstrated, based on the very large GRACE program, that even in those that survive the first 15 days, there is a continuing event rate over the course of time. And actually, those that present with ST depression, the non-STEMIs, had a worse prognosis, even adjusting for baseline risks. So this is a very interesting indicator of vascular disease across the territories. We've also demonstrated that unlike trials where we're concerned about the time to the first event, in registries we can also look at the time to all events. And patients suffer more than one event, about 12.5%, one or more MI, about 7.7%, one or more stroke. Half had a further ACS admission with an abnormal ECG. And this is to show you the consistency of the findings across various countries. And this is patients aged 65 and older, a year after their index myocardial infarction. And we can see the unadjusted rates here on the left. These are the observed risks in Sweden in black, USA in green, England in blue, and France in red. And after adjustment for baseline risks, they are much closer together, but they increase in the next 3 years, despite standards of care. Now, what do we think of this? These are the outcomes in individuals with atrial fibrillation undergoing PCI. Is it because of the atrial fibrillation, or because, as you've heard from Graham and from others, of the comorbidities that run with the atrial fibrillation, like heart failure, poor LV function, poor renal function, and others? And rates of bleeding are also linked to the number of combined therapies. So monotherapy shown on top, and this is from a large Danish program, dual therapy shown here, and triple therapy. The bottom line message is that as you move from single therapy to dual therapy, overall rates of bleeding increase, and they increase further with triple therapy. So our objectives in this analysis are to describe the clinical characteristics of patients with newly diagnosed atrial fibrillation and risk of stroke who have a history of ACS, to determine the differences in antithrombotic treatment patterns, in other words, with ACS and without ACS, prior ACS, how it relates to the CHADS-VASc score, and to look at their patterns of antithrombotic treatment over the course of time, and also to define their outcomes. So let's start with some of the demographics. It's no surprise to this audience that those with ACS have different risk characteristics. Age, slightly older. Male to female ratio, a little different. There's more congestive heart failure, more prior coronary bypass grafts, hypercholesterolemia, vascular disease. You're going to hear a lot about vascular disease in various territories in this Congress. Stenting and diabetes. You can see that in terms of non-smokers, they're more prevalent in no ACS. Higher CHADS-VASc score in the ACS, the prior ACS, and higher HAS-BLAD score. Now, an interesting question. If you take a patient and ask why this patient did not receive anticoagulation, despite having a CHADS-VASc score of 2 or more, is it influenced by whether or not they have ACS? Very interestingly, you can see that for some, taking an antiplatelet therapy is a reason not to anticoagulate. Interesting. Patient refusal was only about 10%. Other and unknown is a black box. We've got to explore this, because buried in there are so-called physician choices. In other words, physician bias as to whether they might be at some risk, and concern about bleeding. Concern about bleeding. So I would put to you that as a medical community, maybe we are overly concerned with doing harm and less concerned about preventing hazard in the future. So this is the antithrombotic therapy at diagnosis in patients with and without a history of ACS. So overall, what can be seen is that anticoagulation rates with VKA and here with the anti-10As, direct thrombin inhibitors, rather similar, but more antiplatelet therapy, as you'd expect with the ACS. Now, does this vary with a CHADS-VASc score? Yes, it does. Overall, the ACS patients have more antiplatelet therapy, whether they're in low CHADS-VASc, CHADS-VASc of 2 or 3+. And you can see the use of the anticoagulation lower in those with a history of ACS. And still, some patients getting nothing. That's purple. Does it change over time? Very interesting, because early on, when people are concerned about protecting the patients against their ACS-related events, there's use of either antiplatelet alone or combined with an anticoagulant. Use of anticoagulant alone is pretty consistent. But over the course of time, look at this, nearly 40% getting nothing. Getting nothing. So they're being treated with their antiplatelets earlier, but not being treated for their risks of stroke later on. And for ACS population, it is even more marked. So here are the antiplatelets, and here anticoagulation plus antiplatelets. And as those diminish in their need for stent protection, they're not replaced with more anticoagulation. Okay, does it matter? Here are the adjusted hazard ratios for 1-year outcomes. And these are substantial populations of patients with and without a history of AS. And what does it tell us? Firstly, there's overall consistency in the hazard. And secondly, strong trends for more stroke and systemic embolism and more major bleeding in those with prior history of ACS. And in absolute terms, an increased risk, significant risk, all-cause mortality and cardiovascular mortality and new ACS and new congestive heart failure. So we need to be concerned about these, not only in the overall population, but in the population with prior ACS. Interestingly, non-cardiovascular mortality, as you'd expect, was not linked to the prior history of ACS. So how do we put this together? After ACS, especially with atrial fibrillation, event rates increase over time. This is a serious concern. And in patients with AF, the prior ACS confers increasing risks. And these are seen in patients overall and those on antiplatelet and anticoagulant therapy. This combined antithrombotic therapy is associated with a modest increase in bleeding. The major contributions to adverse outcomes in patients with AF and prior ACS are cardiovascular death and new ACS. So this builds on what you've heard earlier. We've got to think beyond a single vascular system and across the vascular beds. Thank you very much.